Our panelists, Dr. Stephen Demarks, Dr. Kinnariwala, Dr. Manoj Matnani, Dr. Mainak Deb, and Dr. Shubhashis Saha. I request all of you to please join us on the stage for the case presentation.
So while they are all settling down, I'll just give an introduction. For the next, the whatever part is left, pre and post lunch, we will be having about 4 or 5 case scenarios. We have allocated about 40 minutes for every case scenario. For the we have a couple of case scenarios which will be 20 minutes, but otherwise it is all 40 minutes. And the idea is that it will be completely interactive. So feel free to ask, all of you can stop us, ask questions. I would encourage the trainees here, both the pediatric and the adult, to just stop them. You can ask questions. The panelists can ask themselves the questions. And I don't know, at the end of it, whoever does pediatric KT knows that there's a lot of questions which are unanswered, but we here are looking for some expert advices, like what is commonly done in the difficult scenario. So you can start.
Good afternoon, everyone. I will be presenting a case of a 3-year-old boy with stage 5 CKD, secondary to dysplastic kidneys on peritoneal dialysis. KB, a 2-year-old boy, had presented to his pediatrician with seizures and was found to have low serum calcium, high phosphorus, and elevated PTH. He was treated for hypocalcemia at that time and was investigated further for the endocrine problem of PTH receptor defect. No renal investigations were done. 2 months later, he presented as an emergency with breathlessness and vomiting, found to have anemia, metabolic acidosis, and raised BUN and a creatinine, and needed emergency acute peritoneal dialysis. His weight was 10 kg with Z-score of -1.1, height of 82 centimeters. His blood pressure was 86 by 50 millimeters of mercury. Body surface area was 0.47 and with a BMI of 14.9. He was anemic with hemoglobin of 5.4, BUN of 70, creatinine of 4.5. He was hyponatremic, hyperkalemic, and acidotic with a bicarb of 12. Calcium showed 6 mg per deciliter, phosphorus was 7.4, and an alphos of 450. Uric acid being 6.5. Urine routine showed no proteins or trace proteins, no cellular sediments or cast. Urine protein creat ratio was 0.66. Ultrasound showed bilateral small dysplastic kidneys. A diagnosis of bilateral hypodysplastic kidney with CKD stage 5 with failure to thrive, short stature, hyperkalemia, metabolic acidosis, anemia, and hyperthyroidism was made. He received 1 blood transfusion on peritoneal dialysis. After 72 hours, PD was stopped. Started on oral alkali, phosphate binders, iron, erythropoietin, and activated vitamin D. A temporary HD catheter was inserted and a gastrostomy was done, followed 1 week later by a CAPD catheter insertion. He received hemodialysis during this period and also needed 2 more blood transfusions, leukodepleted and irradiated. A CAPD was initiated with a break-in after 1 week and was on regular cycles after 2 weeks. He was started on nocturnal intermediate peritoneal dialysis with a cycler. Later on, a day dwell was also added. His appetite improved and he was given additional feeds through the gastrostomy tube. His metabolic parameters improved. At 3 months follow-up, he had HB of 10, calcium of 8.9, phosphorus of 6, alphos decreased to 200 with PTH of 350. He was now, sodium was 136, potassium were normal, and bicarbonate was 24. There was a slow improvement in his weight. He had a urine output of 4 to 5 ml per kg per hour. At 3 years 9 months, his weight was 13 kg, height was 90 cm with BP of 90 by 60. He was planned for live-related renal transplant. Child was B positive. 3 potential family donors with the same blood group were identified. Mother 40 years, father 45 years, obese, and a grandmother 63-year-old but pre-diabetic. Mother was identified as a potential donor, 40 years, B positive, non-diabetic, non-hypertensive, normal renal functions, non-proteinuric, with a GFR of 90 ml per minute per 1.73 meters square. The anthropometry of child and mother were compared. Weight of child was 13 kg while mother was 68, height of 90 cm. Body surface area of child was 0.56 while the mother was 1.79. BMI of the child was 16 and BMI of the mother was 23.5. Both were normotensive. Urine output of the child were 4 to 5 ml/kg per hour. HLA typing done showed 5 by 10 mismatch, CDC crossmatch and flow crossmatch being negative. No anti-donor antibodies were there. CMV and EBV were D plus and R minus. The issues of concern were low body weight, large kidney size, and polyuria.
Yeah, I think this is something we all commonly encounter. I saw Dechu's look of surprise that no renal investigations were done. But this is extremely common, which everybody practicing here will vouch for, that pediatricians miss renal problems and especially renal failure. So it's not at all uncommon. They are otherwise very good pediatricians, except for kidney. Okay. Because they thought of PTH receptor defect, which I was totally unaware of, that what could they be thinking? And they didn't do a simple BU and creatinine with such a phosphorus staring at the face. So I think all of us face that these children who could have been picked up earlier come as emergency and then go through a lot of things which they need not go through. And then we face them first, for the first time, as CKD5 as an emergency. And after stabilizing, we have to go forward with the thing. Now, so we are moving a little away from immunology. I think all of us are enlightened, though we have a long way to go to understand it fully. But in pediatric transplant, there are many issues which also need to be addressed beyond immunology. So I identified two major issues which we all face in smaller children. That ours is always, almost always a live donor transplant, and it's usually either parent or grandparent who's donating the kidney. So this is a child with low body weight. I didn't get a clear cutoff that what should we call low body weight. There were some papers which took less than 20 kg, some which took less than 15 kg, and some which took less than 10 kg. But I've taken 15 kg as a cutoff, which we commonly, I think many of us practice that as a cutoff over here for what we consider low body weight, and a large donor kidney. Now, the body surface area relates closely to kidney surface area. So body surface area of donor upon the body surface of recipient may give some idea of the disparity in the sizes which we are facing. So that was about 3.2 in this child. And so various intraoperative and postoperative concerns we have. So I would like the first thing to address with the surgeons first, the transplant surgeon, of three issues that I think some of this was discussed earlier, but I would like to know your practice and your perspectives about placement of the graft, the vessels you would choose for anastomosis, and any issues regarding abdominal wall closure which you would anticipate.
So, as I told you before, as I spoke before that, most of the time a retroperitoneal approach is preferable, at least in my practice. I don't want to go for an intraperitoneal approach unless I'm really forced to.
I think your mic is maybe...
Am I audible now?
Yeah.
Right. That's a little closer then. So I would rather prefer to go for an extraperitoneal approach for the reasons I elaborated earlier. I personally have never had problems, even in children around 10 kilos of weight. And the point that I'd like to make is most of our donors are mothers, and their kidneys are smaller than the fathers. And I think that contributes to their sitting in the retroperitoneum, even in the smaller children. Fathers are not very common donors in our scenario. I think most of you will agree. It's most of the time that we get the mothers, and that helps in a way. I don't want to say that that's the preferable thing to do, but it helps that it sits in the retroperitoneum easier. The problems with putting in the retroperitoneal are quite a few technical problems. One, the bowel is all over the place. So you're opening up that child to a possibility of an adhesive obstruction post-op. Secondly, with that bowel flopping around, it's difficult to isolate your vessels, visualize the vessels, and continue with your anastomosis. And thirdly, in the post-operative period, whatever you try to do, fixing that kidney in a flap under the peritoneum, whatever, doesn't work very well, and the kidney tends to keep moving up and down. And although personally I have not had that problem, but it opens up the kidney to potential vascular compromise. So most of my patients, a large percentage of my patients, we have been able to put them into the retroperitoneum without any problem. We've not had, thankfully, major problems with, so I have not personally resorted to doing a ventral hernia or doing mesh repairs, but that is a possibility that might occur in a very small child with very large kidneys. The other question was
the vessels.
yeah, the vessels. So whenever we've had a small child with a large vessel, our experiences, we've either had to anastomose to the common iliac artery or to the IVC, and very frequently to the aorta, just above the bifurcation of the iliac vessels. But that works well. I mean, it's not such a technical challenge to do. You could always partially clamp the aorta, and these children tend to tolerate even complete aortic clamp, infrarenal aortic clamping, and complete infrarenal IVC clamping for the duration that the anastomosis is going on. But for most cases, a side-biting clamp does not lead to a complete occlusion of the vena cava or the aorta, even if you needed to do that. So I think they tolerate even a higher anastomosis on the aorta as well as in the IVC quite well.
Ma'am, I had a question in this.
Yeah, sure.
Like, preoperatively, can you sort of decide whether you will be going, like this child will be needing intra or extra, or is it always?
No, my
when you
first preference is always to go for a.
Yeah, but then can you decide, like?
So my experience with intraperitoneals have been very, very limited. I've always gone for an extraperitoneal, and in the one or two that we've done, intraperitoneal is where I have converted my incision into an intraperitoneal approach rather than go for an.
And how do you counsel the parents? Like, do you tell them that there is a possibility that?
Yes, you obviously do. In a small child, you obviously do, and then sensitize. And it's always good to, adhesive obstructions is something that you always need to talk to parents about, whether you're doing a renal transplant or you're doing an appendectomy. So those are the counseling points that you would talk about whenever you're talking about the transplant.
Yeah, Dr. Marks, you're.
So we always do duplex ultrasound to look at the actual size of the vessels pre-transplant, and especially in the small kids, we've had a tendency to do magnetic resonance, so time of flight sequence, so you don't need to give any gadolinium or any contrast to actually look at the size, because the smallest we've gone down to is about 7.8 kilograms, and as you said, the difference is we do have a lot of 6'2" fathers that end up donating, and the size mismatch. So for your question about abdominal wall closure, we generally go for primary abdominal wall closure, but recently we've had a few cases where we did have to use a mesh, especially those kids that have got other syndromes, not as in this child, but are syndromic or have more risk of having vascular anomalies will have a lower threshold for doing magnetic resonance beforehand.
Our protocol is generally to do a Doppler ultrasound to assess the size of the vessels. But the problem with this kid, you would expect that the external iliac would be a very, very small vessel. You would probably not be using the external iliac, not only for the size, but that if you place the kidney in the retroperitoneum, your vessels wouldn't line up with the external iliac. They'd be preferentially lining up with the common iliac or with the vena cava. Or the aorta. So you would end up using one of the more proximal vessels, even if you wanted to use the more distal vessels.
One question, do you also decide about which vessel you're going to anastomose with in advance, or is it on the table as you see the sizes?
In an older child, we know that we'd like to use the external iliac, right? But in a smaller child like this, it's more an eyeballing and seeing where the vessel lies without kinking and hooking, so that you don't have a postoperative vascular compromise. So, and when you sight that kidney down there, it usually sits alongside the common iliacs or the bifurcation of the aorta. So it's in the smaller children. But in the older children or the longer children, if I would say, they do line up with the more conventional sites for anastomosis.
Yeah, I know both of you mentioned it's not just the weight, it's also the overall height and body size which can accommodate. So Dr. Marks, is there some cutoff for height, or it is just area?
Yeah, so we don't have a specific cutoff, because we don't have a cutoff for weight either. but it is about the growth of the child. So although we don't use growth hormone routinely, I have used it in some kids to just get them to grow a bit quicker so that they can receive a transplant a little bit earlier. And as you said, it's the longitudinal growth which gives an indication of the size of the vessels for the surgeons, which I think is so important.
Okay, just to catch this point, I had a child who I transplanted the third or fourth, I remember exactly. He was 10 kilos and we started him on CAPD first, and we waited for 5 years for him to get 15 kilos because it was very difficult. And then he was 10 years by that time and 15 kilos, and then we were able to transplant. And the comment on almost all the patients which we have done are pediatric, the transplant surgeons. They are all adult urologists, by the way. So they are extremely resistant to put it intraperitoneal. They say, no, we'll do it. Even if it's a small kid, they all want to do extraperitoneal. They say, we don't want to have this lafra of going into the peritoneum, touching that. I mean, the hazards of all that. So they're all.
So I'm exclusively a pediatric transplant surgeon, and even I would stay away from the intraperitoneal cavity if I could.
So
I
just
think, yeah.
one comment about ideally, I think we should not wait for 5 years for the child to grow up, because the child will never grow up. So that is and particularly in India, growth hormone is also often not feasible. So that is a message that should go out, because I believe there are many adult counterpart also here. And often I get referral at a late stage saying that they have been going to the nephrologist and have told that bada hoga tab transplant kiya jayega, but the child will never grow up.
Yeah, can you use a mic so rest can also hear, please?
So question, Dr. Menak, as you said that you are going to decide on table which anastomosis to take. So does your, before going for this donor nephrectomy, so how do you decide about the stump, the renal stump, for the donor nephrectomy?
The donor nephrectomy is standard, irrespective of the size of the child.
Irrespective of whether you're going to anastomose to the external iliac
Yeah,
versus
the donor nephrectomy
common.
is standard, Kalam. That doesn't change. You want the longest stump of artery, the longest stump of vein, the longest length of ureter that you could get
So
from
that
the
does not
kidney.
change.
Yeah. So then you tailor the donor vessels according to the needs of the recipient vasculature. So the donor nephrectomy doesn't change, and the donor surgeon does whatever he or she wants to do, but give us the best kidney, or more kidney in the best situation possible.
Sure.
Right?
Okay. Yeah. So I think by and large, I think the tendency is we are all apprehensive of intraperitoneal placement. So our tendency is to keep the child better on CAPD till they can go to a little bigger size, rather than take an earlier transplant in a young child. If the transplant surgeon feels that this may not be extraperitoneally placed, which of course depends on each person's experience and skill and learning curve of doing such small children. Yeah.
Yeah. So, ma'am, I don't think that the determining factor should be whether or not it's extraperitoneal or intraperitoneal. That's not your point. The point is that a small child has other issues as well. It's just not the siting of the graft. It's how it's going to mismatch the immediate vascular, immediate hemodynamic compromise that a small child, you put in an adult kidney and you declamp, and the whole blood volume of the kid has just moved into the kidney and child collapsed. And we've had that happen. So, so you need to take those into account.
True.
It's just not the size, and and just the consideration of an intraperitoneal versus an extraperitoneal placement should not guide the need for the indication for the transplant. The transplant should proceed on its own merits. The siting will depend on how you can do it best given at that point of time.
We're the same, and we
Totally,
would discuss with the surgeons, and as you said, very often it's them eyeballing intraoperatively. The only caveat would be if the vessels were very small on imaging. That would be when they say, well, maybe we should wait for the child to grow a little bit, but not 10 years. Well, 5 years from dialysis. Can I ask you a question? I wasn't sure, but why did your patient start on PD, then go on to hemo, and then back to PD? Because you've used a vessel for the hemodialysis, and you have to think of the longer term. If that was our patient, normally we would just have started on peritoneal dialysis from the start?
Well, I think he was in a different hospital when
Okay.
he came as an emergency, and the PD was done there, and then he came to us
So it was an
after.
acute PD stab that they did?
He already had an acute PD
Okay.
stab, and the PD was omitted after 72 hours.
Okay.
And then he came to our hospital, and we started on HD in preparation for CAPD. We wanted to do a gastrostomy first and then a CAPD, and that is how he had an HD catheter, which was for, I think, about 2 weeks as a temporary HD catheter.
But obviously, you've used a vessel,
we've
for,
used a vessel, yes.
for the future.
Yes,
So generally,
yes.
we wouldn't put acute PD. We would have gone straight for a Tenkov catheter, and then you could do a gastrostomy
Right.
later. And
True.
yeah, but
Yeah.
I just was interested. Thank you.
Yeah. So often for us, there's a little time gap that happens before we can, get everything together. And so in the interim, we often do a temporary hemodialysis because it doesn't happen that back to back. That's also one of the reasons. I agree about that. Most of the time, 75% of the time, mothers are donors. Indian mothers are slightly small built, so it's not such a big disparity. But this mother was a very tall, well-built lady, which may be good for her. But we were kind of, taken aback that how's her kidney going to fit in him. Okay, so we go on. The other issue was what you brought up. This is a child with low body weight and a large donor kidney. Now, the adult cardiac output of 5 liters, 20% goes to kidney. Each kidney receives 500 ml blood flow per minute. Now, in a 13 kg child, the cardiac output would be close to 1 liter per minute. And so, would that cardiac output be able to maintain the graft perfusion, or would, as Dr. Deb said, would there be a cardiovascular compromise which could happen, and can that be managed with just fluids and vasoactive drugs as usual? Yes, Dr. Mark said.
So it's very complicated, and nobody actually knows the right answer. Especially, as I said, if you've got a 6'2" father whose systolic blood pressure is 140, and you're going into an infant on dialysis whose systolic blood pressure is 60 to 70. So I think we give lots of fluids intraoperatively. And when you look at it, it can be 200 to almost 300 mils per kilogram in some cases. But as you said, then there gets the discussion, and I think intraoperatively, speaking to the surgeon and the anaesthetist, because very often, if you see that the kidney gets a little bit dusky intraoperatively, you know what blood pressure that you're then going to be aiming for. So if it got a bit dusky when the systolic blood pressure just dropped below 100, you're going to make sure that at least for the first 48, 72 hours that you're maintaining a systolic blood pressure above that level.
So there are two components to this. The first is the immediate post-declamping hemodynamic shifts. Now, those are very acute and can lead to catastrophic problems. We've had children go on to a near arrest and then come up. Sometimes the anesthetists are a little wary of fluid overload, and they're a little wary of the hyperchloremic acidosis that they get when they load sodium chloride. But, well, you need to push them to keep the preload up and keep the peripheral. So the preload is not necessarily the prime determinant of peripheral perfusion, but so you need to do what you need to do to keep the peripheral perfusion going. So and having a good fluid volume input is one of the key determinants to ensuring that these things are minimized. And as you go along in the post-op, I think we mentioned that, I think Dr. Guleria was mentioning that these kidneys generally come back, shrink to size, and then grow. So once you're past the first few days of these fluid shifts, things generally tend to. The other problem that you have is that sort of if it's a big kidney and you close the abdomen tight, there is this relative abdominal compartment, which may negatively impact the renal perfusion. So we need to be careful about that as well.
Yeah.
Just on the comment about perioperative fluids. We've just had accepted for publication. We did a randomized controlled trial versus standard crystalloid with Plavulite. And these new, well, they're not so new now, but these new different regimes, you can see actually you get less hyperkalemic metabolic acidosis, and I think that's really important. And the other thing we showed actually is that you change the fluids post-operatively less frequently, so therefore you have less errors, I think, in the staff using it. But I think the type of fluid is really important, but also the quantity, and our next aim is to do a randomized controlled trial to look and see different fluid regimens. I think, though, as you said, in this case, it's a bit more difficult because a small infant with a larger donor, we're going to want to give huge amounts of fluid for the reason that you said for your patient, yeah.
So, Steve, I was going to just ask that question that have you now changed to plasma light?
So we've just had it accepted for
Yeah, I know that,
publication.
yeah.
So we are now having internal discussions within our group about whether we use this as standard fluid. Because obviously we have to have agreement with all the anaesthetists, because obviously it also includes the deceased donor transplant, so it's not always our pediatric renal anaesthetists who obviously do our living donors, which we have lists at least twice a month.
And before we were going on chasing so for the first say 24 hours, we were aiming for a CVP above 12, and whatever comes out
Yeah,
goes
we are
in.
touching that, Rajiv. Can we go to the next issue? Yeah. So we have also increasingly started using balanced solutions from extrapolation from what's happening in critical care. But when you have to give those rapid build-up of CVP, when it's remaining low in the last half an hour or 45 minutes, we tend to use saline because we are afraid of how much potassium we may be pushing in at that point. So we are using right now a mixture, but we do see less acidosis, definitely.
So when we set up the trial, there were some centres that wouldn't join because they said we're too worried about hyperkalemia, and actually the randomised control trial showed it wasn't an issue, which is what physiologically an anaesthetist would tell you as well when they use it as their standard regimen.
Yeah. So before we move to the next part of it, Kinnari, what is your practice in your center for, what is your cutoff for what you call a low weight baby, and
So,
do you do intraped?
madam, we have done so far, if we take 15 as a cutoff, then we have done so far 5 to 6. The lowest was 11 kg, where we had faced similar difficulty when mother was a donor. And there, like we had to use PCV, even if the hemoglobin was good, 11. Generally, what we do is we try to achieve blood pressure of donor's blood pressure. And with the use of fluids, like you said that if it is the last 30 minutes, 45 minutes, we give bolus. And if with that, if we're not able to achieve, then we use inotropes. And we do one blood gas before clamp release in very low weight children. And there we do see hemoglobin. If needed, we give PCV. But we generally in like 10 kg, 11 kg, with such a huge cardiac output of a donor. So we have used PCV in that child.
So is it all extraperitoneal?
It was extraperitoneal.
Okay, okay.
I was going to ask you what's your preferred inotrope, because of course that's a whole other debate.
Yes.
So sir, we do start with norepinephrine. We have discussed also that case with you on a webinar, and we had used norepinephrine, and you had also agreed to that should use norepinephrine.
There is a debate. Some people still use low-dose dopamine, but obviously vasoconstriction is a concern for our surgeons as well with inotropes.
Yeah, Manoj, what about blood transfusions in such small children? In not because the hemoglobin is low, but because you're putting in a large kidney with a low cardiac output, relatively mismatched cardiac output.
So I remember we always keep ready the packed cells, leukodepleted and gamma irradiated, which you all also have done. We hardly use it, but once or twice when there's excessive bleeding, the anesthetist orders that and then we use it. So we do the packed cells, leukodepleted and gamma irradiated.
Yeah.
And my question was actually about a replacement fluid. What do you all use? We use more of ringer lactate rather than the 0.9 NS. So I was wanting to know whether you're coming there to that in the question later.
We're
or
using plasma light
you're using plasma.
because the anesthetist prefers that.
And our anesthetist prefers ringers like
Yeah,
that. That's
but
the
I think
reason.
it's okay, all balanced solution.
And what about
I would like to know your opinion regarding blood transfusion in this situation to ensure good graft perfusion on releasing of clamp.
I mean, obviously,
Only I'm talking of the low weight children.
yeah, so it's a very big issue, and it's one that we always consider. And obviously, we're worried about sensitization, especially kind of early on. We do not routinely give blood transfusions in that case, but as Manoj says, I think if they are having excessive blood loss at the time and you're running into problems with perfusion and maintaining blood pressure, then we would advocate. So we always have blood ready as well. But it's very rare, when we looked at our series, it's very rare for us actually to use PAC cells intraoperatively.
Okay. Yeah. And the other is, I think we already mentioned it, but the target map would be the donor's mean arterial pressure, which you're targeting. So this child had a 90 by 60 BP and sometimes 86 by 50 kind of blood pressure. So the choice of vasoactive drugs, because just fluids may fill up, but the BP still hovers around, and with anesthesia, sometimes it doesn't even pick up. So our choice is also usually noradrenaline. We used to use earlier dopamine, but with dopamine fading away from ICUs itself, and it's not always effective, what we've noticed. It's a hit and miss. We've shifted to noradrenaline in the lowest dose possible. So your comments on that?
So we find that for our patients, if they are small like this and they're in intensive care, then yes, we would use noradrenaline as an infusion. Most of our older children, and usually I mean older, it's at least 20 kilos, but even smaller than that will actually come back to the ward. So if they're in the ward environment, we very often will use low-dose dopamine in that instance because our staff are used to using it, because we're monitoring, and really if we're unable to maintain the blood pressure or are running into problems, then we would transfer them to the intensive care unit to get a noradrenaline infusion as well. But it is very much personalized depending on what the patient's blood pressure is, what the donor's blood pressure is. But actually, I think the other aspect is that if you are 48 hours later, you're not quite maintaining that blood pressure, but the creatinine is coming down beautifully and all the other parameters are fine and you've got good urine output, I tend not to worry too much about the blood pressure at that point, because I know that ultrasound looked good, I know that the surgeons were happy intraoperatively, and you've got a good functioning graft.
Yeah, so how long post-operatively should we continue the vasoactive drugs? Would it be like first 24 hours, 48 hours?
So generally it depends on the response, but usually it's 24 hours. We try and wean them off if we can, and generally that's quite successful. But as I said, if the urine output and the creatinine are coming down nicely, then we're reassured. Sometimes we're in the situation where the urine output is a bit variable, and in those instances, we will probably continue the vasoactive drugs to keep that blood pressure a little bit higher for a bit longer.
And I think the blood pressure also tends to go up a little in the post-op with all the methylprednisolone that has been given.
The steroids, and once they're waking up and in pain, and when they're in pain as well, that tends to bring it up.
Yeah. Will there be unrecognized subclinical graft hypoperfusion leading to slow graft dysfunction in the long term? There are some papers to suggest that it could happen, but does it happen?
It's a very difficult question, and I don't think that we really know. We do on the table in the operating theatre, we do an ultrasound, or at least in recovery, before they go to intensive care unit or back to our ward. As I said, most of them come back to our ward. And if there's any concern at that point, then we've got an early threshold for the surgeons going back in and having a look at the vessels, because as you said, It may be that intraoperatively you weren't sure, it looked a little bit dusky, the vessels, you weren't sure if they were kinking. But I think, as you said, to say that you get graft hyperperfusion leading to longer term graft dysfunction, if the blood pressure is okay perioperatively and you've seen intraoperatively your findings, then I think as long as the patient is doing well at that point, I don't think we would do anything more to try and negate that.
Yeah. The second problem, I think we have only little time left for that, was the polyuria. Now, should we do a nephrectomy? If we should we do bilateral or unilateral nephrectomy? Should we be doing it pre-transplant or during transplantation? From the interests of maintaining the volume intraoperatively and also subsequently the fluid intake of the child to match the output.
I mean, historically, we did do nephrectomies for very polyuric children. And we got to the situation that the surgeons were happy to do a nephrectomy at the time of transplant, but then they got a little bit more worried about prolonging the operation, additional risks. So we've generally stopped it. And the one or two kids where I thought, oh, maybe we should do this, have actually done reasonably well, although their fluid requirements intraoperatively can be massive. And I think one thing which is really important is intraoperative management of the patient, but looking in to see what's the total volume of fluids that we can give in, but actually what the urine output is. So you may find that you're giving a lot of fluids, but if you actually look and see what the urine output is during the operation as well, you can sometimes be surprised just how much more polyuric they are because you're pushing lots of fluids as well.
Yeah. So any inputs from any of the panelists according to their practice or?
So, sir, we don't do nephrectomies. Our surgeons also, unless if it is a refluxing unit and if that needed, then only they do nephrectomy. Otherwise, pre-transplant or during transplant, we don't do nephrectomies.
Okay. Manoj, any difference?
I think the indications for nephrectomy are very, very restrictive. It's only if it's a severely, a lot of nephrolithiasis, stone disease, and if it's an infected system, refluxing, as Kinnari said, infected, and like if there is a big kidney in a very small infant.
No, those are accepted.
Those are different.
I'm talking in purely
in a
for
pure
a small child who's polyuric.
think,
This is not 2 ml per kg per
got
hour.
it.
This
So-
is 4 to 5 ml per kg per hour.
We had
And do
patients
we
with
know after transplant, does the native urine dry down? Will the child be able to manage with fluid intake? Till he's in hospital, we may give intravenous for the first few days to meet the needs. So with those concerns of ability to continue taking a large amount of fluids, would it be indicated? And is there a level of polyuria which we should consider where we should address? Or it doesn't matter
So
what?
I haven't done it in my practice. We just do mil for mil replacement for first 24 to 48 hours. The creatinine beautifully comes down, and then we go cut the polyuria by decreasing the intake. Yeah.
So I think there were other questions regarding the nephrectomy. Is there a role for medical nephrectomy, renal artery embolization? There was even some mention in literature of native urethral ligation for if you want to remove that kidney for whatever reason. So is there some role for all that?
We've done an embolization and we've also done a urethral ligation, but it is very rare. We did it as a trial to see what the response is. But usually it's in those patients that have failed using ACE inhibitors. I mean, obviously you want some residual renal function if you can, so it is nice not to, but in an individual patient, I think it can be considered. The other thing to say, obviously, in other patients, the other reasons for doing a nephrectomy would be like polycystic kidney disease, where you've got huge kidneys and a huge liver, where there may be space issues for the surgeon. And the other aspect would be if the child had an underlying genetic condition like a WT1 mutation, where there was a risk of malignancy
Our
developing.
question was primarily like any level of polyuria, say the child is already passing 7 ml or 8 ml per kilo per hour of urine before transplant. So do you have any level of polyuria where you'd go for nephrectomy pre-transplant?
Are you speaking of a preemptive or a patient on CAPD?
Pardon?
It depends all on, are you speaking
No,
about a
this is
patient?
pre-transplant. Do
No,
you
but is it a
want to
preemptive
address?
transplant or a patient on CAPD? Because usually,
Whichever.
so if anyway, I'm speaking about the fire when I kept the child on 5 years CAPD, the urine output, the residual renal function starts decreasing.
No,
and
that's
the
okay.
child- that's
At
different.
the time of transplant,
If he's
if you
already
have
polyuric, what's the question?
We usually don't
Yeah.
do nephrectomy for that.
Yeah, so
Not
there's
really.
very little literature
Yeah.
on that. There are just few retrospective studies, and this was the largest I found, where Dr. Martin Bitson is a co-author. 49 patients with nephrectomy out of 126 children who underwent KT. 22 were for polyuria. Okay, so there were different techniques they used, but they used a very much more conservative cutoff, or I would say higher threshold. They used, when the urine output was 2.5 ml per kg per hour, anything above that.
I think there is also a theoretically, like more than polyuria, if there is high proteinuria, that sometimes
Yeah.
leads to a lot of loss of coagulation factors.
Right.
And the transplanted kidney, there is a chance of this thing
that will
Yes.
the FSGS one.
Yeah.
selected.
I think more or less we've covered most of the talk, and I think we've run out of time. It's showing time map, so I won't go with the further course of the patient. That was just to sum it up. But he underwent a successful transplant. We did give one transfusion because we were afraid he may not perfuse adequately because his BP is kept around 90 and we had to go up on the NORAD as well. A CVP almost of 18, the anesthetist took it up to. But we had prompt graft perfusion and he was fine after that. So thank you, all of you.
Thank you.
For
Thank
the
you.
inputs.
Thanks to all our panelists, moderator and presenter. Thank you so much.